Well, it looks like it's going to be showtime.
The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everybody. We're back in Chicago with some good old-fashioned rock and roll. Good morning, everybody. This is Dr. Minarsik, and we're back in Chicago again. It's Tuesday today. It's October 25th, and this will be our 11th two-hour session in Global Medical School Pathology. How is everybody today? I hope that you enjoyed the music. The first thing that's really on my mind today, to get it off my chest, is I have to make an apology for Las Vegas. We have given all of these sessions from Chicago with amazingly good clarity and bandwidth and no problems, good connections, good audio. And I realize that when we were in Las Vegas last week, there were a lot of people that experienced audio problems. Some of them were quite severe. Some of them weren't that bad. I guess I should probably do a survey now because I feel real sensitive about it. So I'm going to do the little survey here and just ask a question that's I probably don't want to ask. First of all, let me ask, did any of you feel that last week in Vegas, if you were there, by the way, that you basically had adequate presentation of audio and video? I know it wasn't great. I'm hoping some people would say it was adequate. Okay, well, I got one or two. Okay, somebody said poor audio, somebody said good enough. Well, I know there were some people with problems, and I apologize. That's what I wanted to do. But I wanted to tell you that Lynn, who is our technical director, was able to get a pretty decent recording or archive of Vegas session number 10, which was the second part of immune diseases. So if you had problem being there personally, at least if you play the video on GoPath, it's not too bad. It's not great, but it's not too bad. It's adequate, and I see some of you already thought it was halfway adequate. Usually if only one or two people have an audio problem, I tell them it's their fault. But when a lot of people have audio problems, it's my fault. And it was the fault of the hotel. I stayed in an $1,100 a day room and paid an extra $13 a day just for internet, and it was crappy. And man, was I mad. I went to the girl at the desk and I said, "You screwed up my webinar." So she gave me my money back for the internet, but she couldn't unscrew up the webinar. Anyway, that's the apology I wanted to make. I'm not going to go back there. I'll be broadcasting from Virginia probably next week, and then maybe from some Caribbean island a few weeks after that. But for now, we know in Chicago we can get rock solid bandwidth. Another apology I want to make. Well, what happens in Vegas doesn't stay in Vegas. I got to apologize for it in Chicago. Another smaller apology I want to make is that when I went over the Chapter 7 PowerPoints, which we'll be dealing with today on neoplasms, I noticed that the first 15 or so were missing. So if you are a conscientious student and you download the PowerPoints before the lectures, you're probably saying, where the hell are the first 15 or 20 PowerPoints? Well, I don't know what happened to them. They probably vanished. Sometimes I have this crazy habit of hitting the delete button rather than the page down button. So I went back to one of my old files and I put them back in, and you'll see them here today. I fixed it. And I uploaded them too. So if you uploaded them yesterday or downloaded them yesterday, a lot were missing, but if you download them now, they're all there. And if you listen to me today, they're all there as well. Okay, now let's talk about the matter at hand. Session number 11, chapter number 7, neoplasms, tumors, neoplastic diseases. I have to say something about this really big topic. If you remember, since day one, we've been saying that all diseases fall into the category of either degenerative, inflammatory, or neoplastic. And we've had many of the inflammatory diseases. We've had inflammation itself. We've had the autoimmune inflammations. We have not had the infectious inflammations yet. That's coming. But the next big topic is neoplasm, tumors, benign, malignant. And let me tell you, this is probably every pathologist's dream, is to talk to medical students about cancer, because even though it's theoretically 1/3 of all diseases, it's what we spend most of our time on, is finding cancers, finding early cancers. That's how pathologists save lives. They never get credit for it, but it's a good internal feeling. And people that become pathologists don't give a damn whatever people think about them. They just want to have that good internal feeling of knowing they've saved somebody's life because they were tedious enough to find an early cancer. This will be an extremely graphic chapter. It will have tons of great pictures, gross pictures, microscopic pictures, and that's basically what most medical students think pathology class is going to be like. The pathologist showing a lot of pictures and specimens and slides, and it's going to be very heavily graphic. It will also be the biggest lab. If you've looked through Rock Lab already and look at the different things that we have in Rock Lab, you'll see this neoplasm chapter has about 10 times as much material as any of the other chapters. All of this will be repeated when we get to the individual systems. So I may not do all of the cases, but I will do a large number of cases. Last year what we did is we took 2 entire sessions to discuss the chapter, and then we did 2 entire sessions to discuss the lab. So this is going to go on for about 2 weeks, most likely. It's also the chapter that's the most appropriate for pathologists. In my opinion, it's also the most fun. I mean, no pathologist loves anything more than talking about cancer, because it's also an apologetic for his life, what he spends his whole life doing. And every pathologist thinks that he is an expert on cancer, and then the medical oncologists come around and they say, oh, you only see one small part of it, you only see the microscope, I'm the one that looks at the patients. So we'll have a lot of fun for the next few days. I did have to work hard to prepare for the fun, though, and I want to tell you that even though a lot of it is really cool stuff and stuff that I've known my whole life, there's a very large amount of material in this chapter which I would call newer stuff. In other words, a lot on genetics. And even if you graduated from pathology school 2 years ago, the amount of material on tumor genetics and molecular pathology of tumors like triples just about every year. So I always have to work very, very hard to keep up with that. But I also have to be careful not to bog you down with the biochemistry details of a lot of this crap, because if you do, then you lose the whole big image of cancer and patients with cancer if you're looking at, you know, tiny little nucleotide changes and diseases all the time. So having said all that stuff, I could see we have a lot of people here that can hear me and see me, but I'll ask you the question anyway. You know the drill. Can you hear me? I want everybody to answer. Of course, if you answer no, that would be impossible, but I see a whole line of yeses here. And then the second question is, I have an incredibly good new digital camera. It's 16 megapixels, and I put a picture on my screen, so I want to ask you if you could see my screen very well also. And what do you see? Yes, you see Lady at Death Valley. That is my friend Marilyn. If you go to Las Vegas and you don't gamble, you're a real winner, because there's so much beautiful stuff near there. There's Death Valley, there's Lake Mead, there's ghost towns, there's Valley of Fire State Park, there's Hoover Dam. I mean, you could just walk through the desert and overturn rocks and catch scorpions. I mean, this is really one of the most beautiful areas in the whole world if you don't gamble. So that's what we did. We had a really good time and took a lot of good pictures. I want to show you one more thing. Another picture I took. This was the view from my window on the last class that we gave. That's the view from my $1,100 a night room at the Palazzo Resort and Casino in Las Vegas. It's awesome. You can see the Sunrise Mountains. If you see the mountain up here where my arrow is, that's approximately where the sun came up as I was speaking to you. Big golf course, swimming pools, the whole eastern part of Las Vegas, the part that's not the Strip. And it just was a beautiful sight. So how about if we talk about tumors now? The topic is neoplasm. We'll be talking about tumors for the next 2 weeks, both in lecture and in lab. This is a typical tumor. For most pathologists, they probably would see this instantly and say, carcinoma, probably breast. I don't know what you think when you see it, but at least you could see a disorganized array of cells that doesn't look like it's growing like anything should grow like in normal histology. Most of the really spectacular pictures, like this one, especially the microscopic pictures that I have, I digitized directly from the University of Iowa's virtual histopathology site. So if you want to see, if you have to give a presentation on a normal thyroid or a follicular carcinoma of the thyroid, go there and just do a screen capture, and it will be so much more dazzling than any other picture you might download from the internet with your little Google search. We'll be talking about neoplasia. Same thing, tumors. This is the organization of the chapter, and it's a pretty good organization. We're going to be getting into a lot of the original definitions, proper terminology. Even though a lot of them are used wrong, I want to make sure you start out right. We're going to talk about the pathobiology of tumors. It's a little bit about epidemiology, a lot on molecular basis of cancer, and probably a good amount on molecular basis of carcinogenesis. For the most part, at least the first part of this chapter, there's a lot of very logical, easy to remember, smooth flowing stuff. I will have to throw in some rote stuff when we get to carcinogens and stuff like that, and even some of the genes, which I normally would want to skip, but I think you really have to know them, because those stupid bastards that make up the board questions are going to be throwing a lot of that stuff at you if you want to take the boards, and I think most of you do, step one. We'll be talking about host defenses and a lot on clinical features of tumors too. So let's define neoplasia, as long as the whole chapter is on it. Probably the best definition, and probably the definition most smart people or pathologists will give you. I believe, I don't know if this is from Robbins or somewhere else, but a neoplasm is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of normal growth tissue factors, and persists in the same excessive manner after cessation of the stimuli which evoked the change or caused it. So it's an independently growing mass of cells, tissues. Many of these, as you would guess, are due to genetic changes. Some of them are not. So once again, we have the same dichotomy of nature versus nurture, genes versus environment. Both are important. The key thing to remember from this definition is that neoplasia growth is autonomous. We have a system of growth control mechanisms in our body that is so enormously large, nobody understands it. But whatever that whole scheme of growth control is, neoplasms are generally independent of it. And that's why it persists. And also to remember is that even though a neoplasm can be large, and approximately 1 kilogram of malignant neoplasm is generally what they regard as a lethal burden, all of the cells are clonal. In other words, they come from ultimately one cell. So even though the tumor may show areas of necrosis, tumor may show areas of good differentiation, looking like normal cells, or poor differentiation, looking like garbage, theoretically they're clonal. And there's laboratory tests that you could perform on tissues to determine whether something is clonal or not. I guess you could consider a human being to be clonal, because we all ultimately come from one stem cell, the fertilized zygote. But tumor cells are also clonal, ultimately coming from one cell. So let's get into the proper naming of tumors. And what we'll do is we'll talk about generalities, and then we'll tell you the exceptions. If you have only the word oma after a tumor, and not carcinoma, not sarcoma, but just oma, it's generally regarded as a benign neoplasm. And if you go back to your tissues and your germ layers, and you look at different types of tissues, for example, a chondroma would be regarded as a benign tumor of cartilage, even if there are other adjectives put in front of it, like enchondroma, for example. If it was malignant, it wouldn't be called chondroma, but chondrosarcoma. So the sarc in front of a ma often indicates that it's a malignant rather than benign. Fibrosarcoma tumor that's benign would be called a fibroma. A fibrous tumor that's malignant would be called a fibrosarcoma. A bone tumor that's benign, various types of osteomas. If it was malignant, it would be called osteosarcoma, or often osteogenic sarcoma. Okay, that's for connective tissue. That's for mesenchyme. That's for mesodermally derived tissues. Now what about epithelium? You know, ectoderm is epithelium. Entoderm has epithelium. If you hear the word adenoma, it's generally a benign tumor, and adeno is the root word for gland. So an adenoma is a benign tumor of glands. A papilloma is also an adenoma, but if you remember, papillomas, rather than growing like little tubes or circles in tissue, they grow like little fingers. They have epithelial coverings and then little connective tissue in the middle of the finger. Those are called papillomas. Papillomas are benign. If it was malignant, it would be called papillary adenocarcinoma. So, let's look at another possibility here, after I clean up my typo. A papillary cystadenoma would be a benign tumor of glands, that, for example, that also has a papillary configuration microscopically. We've seen a few of those in lab already. We'll see a lot more. And cyst, implying that maybe there's a lot of cystic, larger, wide open spaces as well. This is so typical of, for example, ovarian tumors. So papillary cystadenoma is a papillary and cystic tumor forming glands. A polyp is a very, very generic, nonspecific term, and very often polyps, for example, in the GI tract are equated with adenomas, but technically a polyp is any mucosal or surface blebbing, and they're usually regarded as being benign, but they don't even have to be glandular or even epithelial. So that's the nomenclature: oma, adenoma, papilloma, or any oma following a mesenchymal tissue differentiation name. So what do you think this is? Well, you know it's glands. I can't blow it up anymore because it's just a still picture, but you can see the epithelial covering. But do you see how it doesn't take much imagination, if you look at practically everywhere on here, to see that not only is it forming glands, but do you see how these cells are kind of growing on the outside of a finger-like projection? Here and 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 here. And on the inside of that finger, you see blood vessels and connective tissue. That is a papillary structure. I always use the term finger-like. Throughout this course, we're going to see at least a dozen different examples of papillary type tumors. Now, don't forget, it doesn't have to be columnar epithelium that lines the finger-like projection. It could be squamous. You could have a squamous papillary tumor. But most papillary tumors are glandular. Here's a gross picture. And if you could not use much imagination, you can see this is a part of a GI tract. It's a colon that's been opened up longitudinally, and you could see that there is something growing on the mucosa here, and something growing on the mucosa here, and something growing on the mucosa here. And it looks like it's kind of elevating the mucosa and maybe even the underlying connective tissue with it. These are the classical colon polyps. In this case, they happen to be glandular, they happen to be adenomatous. And if you call it polyp, you're implying it's benign. You could have a focal area of adenocarcinoma change within this polyp, and it would no longer be called benign. You might call it adenocarcinoma. This is the same thing. This is also the structure that I used for the title page of my GI chapter. If you look at this part of the polyp, the stalk, you can see this is the stalk all along the west coast. And then the Midwest and the East is the actual polyp. Do you see when this polyp grows, it kind of sucks up or takes up the submucosa as well. So if you were doing a normal histology exercise, you could see that here are your mucosal glands. Here's some lamina propria. This little tiny muscle strip is the muscularis mucosae. And here's your submucosa. Notice there's no muscularis propria, however. But this is connecting the polyp to the rest of the colon. And if you think that some of these little glands here within this polyp look a little finger-like, like there or there, and you wanted to call it papillary, I guess I could probably agree with you. But for the most part, most of the glands within this polyp are rather circular, or what you might call tubular. That's why these are also called tubular adenomas. But the very, very best honest diagnosis or description for this lesion would be a adenomatous polyp. If you wanted to say it had tubular features over here, if you wanted to hint that it even had some papillary features, that's true also. Now, of course, we don't know if it's benign or malignant, and of course, we're not on high power. If you were on high power and you saw some area here that looked like it was malignant, you would no longer call it a polyp. You might say adenocarcinoma arising within the adenomatous polyp. Okay, so much for benign tumors. Let's go for the general nomenclature now of malignant tumors. Starting with connective tissue again, or mesenchymal derived tissues, or mesoderm derived tissues, or what we call stromal tissues. If it's a malignant tumor of a mesenchymal derived tissue, such as bone, fibrous tissue, or cartilage, whoops, we got another typo there, then the word sarcoma is put in it. So malignant tumor of cartilage, chondrosarcoma. Malignant tumor of bone, osteosarcoma. Malignant tumor of fibrous tissue, fibrosarcoma. And so on and so forth. What if it was a malignant tumor of blood vessels? How about angiosarcoma? How about if it was a benign tumor of blood vessels? Angioma. That's the general pattern. Now, for a non-mesenchymal malignancy, in other words, an epithelial malignancy, almost always the word carcinoma is in there. It might be adenocarcinoma. It might have other adjectives like papillary or whatever, but the word carcinoma means malignant epithelial tumor. So if it's a tumor of a gland or tissue that forms glands, it's adenocarcinoma. If it's a tumor of epithelium that's normally squamous, like esophagus or vagina or cervix or skin, then it would be called squamous cell carcinoma. If it's a tumor of epithelium, but it is so poorly differentiated, you really can't tell if it's even epithelium, they would just call it undifferentiated. And I know what you're thinking. You're thinking, well, if it's undifferentiated, then how the hell do you know it's even a carcinoma? Good question. I knew you'd ask that. You know it's a carcinoma because now we have what we call markers. There are certain markers, antigens we could stain that show that that cell is of epithelial origin rather than mesenchymal origin. And sometimes you know it's epithelial because also it blends in with another part of the tumor that is not so undifferentiated. Now technically, if you normally think of ectoderm and entoderm as producing epithelial structures and mesoderm as producing mesenchymal connective tissue structures, you can, but remember, carcinomas can arise from any of the three germ layers. Now you're probably going to wonder, can sarcomas arise from ectoderm and entoderm? Well, think about it. Not only does ectoderm and endoderm produce epithelium, but it also produces some connective tissue as well. So the flip side of that is also true. Carcinomas can arise from any three. Sarcomas can arise from any three. That's just a moot point. Okay, let's look at this now. Does this look familiar? Of course it does. It's a stratified squamous epithelium. I suspect it's skin. Why? Because there's a granular layer there and there's a stratum corneum. And it looks like even towards the base of this there might even be some sebaceous. Perhaps this was a hair follicle at one time. And we have dermis and we have epidermis. But we also have nests of cells completely within the dermis that look almost identical to the surface squamous epithelium. So, do you think then that the best name for this situation would be an infiltrative, well-differentiated squamous cell carcinoma? And of course the answer is yes. And I want to point out one more thing, is that even though all of this surface stuff here is benign, and practically everything to the west and southwest of this line is malignant, it pretty much looks identical. You know, if you saw this out of context, you might not even be sure it was malignant. And in addition, do you see that in this squamous cell carcinoma, there is a world, W-H-O-O-R-L-E-D, array of squamous cells like you see here and here and here. These are called pearls. And pearls are squamous cells that are arranged in a circular fashion, and they are the hallmark of a good or a well-differentiated form of the squamous cell carcinoma. Now, here is another squamous cell carcinoma. And let's say that you really can't see pearls, in all honesty. However, the one thing that you can see or say, if you think this might be part of a pearl, you know, that's your privilege. You know, I personally think it might be, but let's say you're not really sure. But let's say that you see these tumor cells are growing haphazardly and not looking at all like normal surface squamous epithelium. And you can see that there are tiny little lines between these cells. And I don't know if you're going to be able to see this, but you see that little line between the two squamous cells, that little clear line? And do you see these clear lines? If you look very, very carefully, and also here at these lines, you'll see tiny little hairs going transversely to that little light cleft. Those are intercellular bridges. You'll remember from histology and cell biology, these are desmosomes. These are tonofibrils. Remember that? Well, there's no other type of sheet-like array of cells in which you see those. So if you see those, you know it's squamous cell. It might not have pearls, but if it has these little slits between the cells, you know it's squamous. So this might not be a well-differentiated squamous cell carcinoma. It might just be a moderately differentiated squamous cell carcinoma. Okay, what about this? What can you honestly say about this? Well, from your experience, you could say it looks like glands. And also, if I said, yeah, that's right, but is it growing in a normal pattern like any normal glandular organ you've ever seen? You'd probably have to say no. And then you have to say, well, are some of these glands actually touching each other, or what they call back to back? You see, rather than the glands being separated, here the two glands come very, very close to each other. And up here you might even say they do more than come close. They actually abut each other with no connective tissue in between. This is an adenocarcinoma. This is a haphazard array of glandular growth. And even though we have not gone high power and looked at the nuclei and seen dark nuclei and seen big nuclei and seen bluer nuclei than they should be, or hyperchromatic, this is an adenocarcinoma. In this case, another typo here. In this case, the adenocarcinoma arose in a setting of ulcerative colitis. So we're going to learn about a whole bunch of situations in the rest of this chapter, as well as in other chapters, to show conditions that predispose to malignancies as well. Okay, you're doing pretty good. And we're not really in lab, we're just in lecture, so let's look at the next one. Let's say that you look at this picture now that you have all your experience, and you say, well, it doesn't look good. I see a lot of big, dark, irregular blue, bumpy nuclei there. And we haven't even defined that yet, have we? And I could see between these little clusters of sort of epithelial-looking cells, look like we got some lymphocytes or inflammatory cells. Well, what do you think are the actual malignant cells? These large, dark cells, or the lymphocytes perhaps reacting to them or growing between them? This is an undifferentiated large cell carcinoma of the lung. And because we said carcinoma, we're implying it's of epithelial origin, even though you don't see really good squamous features and you don't see glandular features. It's still a carcinoma. And we'd say, well, are these lymphocytes part of the tumor too? Because no, the lymphocytes are reacting to this. In fact, the general rule is the more lymphocytes you have reacting to a tumor, everything else being equal, the better the prognosis will be, because it means more of these cells are fighting the tumor cells. Okay. Here, let me ask you this question. This is an interesting one. Even though we're not in lab, I'm going to ask a question right now. I'm going to pop out the question box. I know you're all pretty smart. Let me ask you this. If I told you that this tumor here was a very poorly differentiated squamous cell carcinoma, would you believe me? That's the question. Yeah. Well, a couple people say no. But it could be. Let's say that there was a antigen marker for squamous cells, okay? Even though you don't see this on regular H&E, let's say that those markers appeared in the tumor cells. Then, would you believe it was a poorly differentiated squamous cell? Yeah, now everybody's saying yeah. Okay, so I just wanted to show you that just normal patterns of tumors, you could be fooled unless you use certain tricks like antigen markers, or what we call immunohistochemistry, or IHC, to identify what kind of cells they're coming from. Let's say, for example, here's the part two of the question. Let's say we took these malignant cells here, and you've got to believe that they're malignant compared to the benign-looking lymphocytes. And I told you that they stain with for an antigen that is present only in connective tissue cells. So here's my question. Would you then want to call this a sarcoma? Yeah. But the fact is, we don't know what it is. It kind of looks epithelial, and it was called large cell undifferentiated. But without immunohistochemistry, you might just be going on luck and experience rather than scientific proof. Okay, let's talk about more classifications of tumors. We talked about connective tissue, benign and malignant tumors. We talked about epithelial, benign and malignant tumors. Let's talk about a few little curious exceptions. You can have tumors that arise from more than one embryonic germ layer, and those are called teratomas. And you need at least 2 germ layers, and sometimes you see elements of all 3. For example, you can see epithelial structures, connective tissue structures, and teratomas The earlier differentiated a cell is, the more likely it's going to show a wide variety of structures. So teratomas usually arise from totipotential cells, like gonads, for example. So if you thought that most of the teratomas you see in the body are either from ovary or testicle, you're absolutely right. Some cells have both glandular or epithelial as well as connective tissue differentiation. Now remember, we said that an epithelial tumor, whether it's benign or malignant, it can also have some normal connective tissue or fibroblasts or lymphocytes mixed in with it. Well, that connective tissue is not part of the tumor, but certain tumors, like for example the most common tumor of a salivary gland, what they call a pleomorphic adenoma. Pleomorphic meaning it's both glandular and connective tissue. Also called a mixed tumor in the old days, and a lot of people still call it a mixed tumor. That's what they have, a tumor of mixed differentiation. We talked about teratomas arising from more than one germ cell layer. And then we also have terms like hamartoma, choriostoma, and even though they may look like neoplasms, they're really not. They don't follow the true clonality tests of most neoplasms. So in hamartoma is basically described as, it might look like a tumor grossly, but it's a disorganized mass of tissue whose cell types are indigenous to the site of the lesion. For example, the lung. If you remember, the lung has bronchial epithelium, cartilage, alveoli. Well, a hamartoma of the lung usually shows a predominance of cartilage, normal-looking cartilage, and maybe some epithelium as well. Or a choriostoma. It's a term that is almost never used by real doctors. It's only in the pathology textbooks. But a choriostoma is absolutely normal tissue, but it's in the wrong place. For example, sometimes a surgeon will see a little nodule on the small bowel and he's afraid it's cancer, so he sends it for frozen section, and we say, "Don't worry, doctor, it's only a piece of normal pancreas tissue in the wrong place," or what they call ectopic. So it's also called heterotopia. Could endometriosis also be regarded as ectopic tissue? I think it could be, because when you see endometriosis, whether it's in the small bowel or whether it's in the umbilical cord or whether it's on the bladder, it's normal endometrial glands just in the wrong place. So that's not a true neoplasm either. Now let's talk about the exceptions. A hepatoma, even though it doesn't have the word carcinoma in there, even though it doesn't have the word sarcoma, there's nothing in the word hepatoma itself that leads you to believe it's malignant, but all hepatomas are malignant. There's nothing in the word melanoma. The word cars or sarc is not in there, so you would not know if melanoma was malignant. Well, all melanomas are malignant. Same thing, seminoma does not have the word sarc or cars in there. It's still, all seminomas are malignant. And of course, the most notorious example of these misnomers are lymphomas. So if you use the word malignant lymphoma, you're being redundant. However, most of these terms are also used in a redundant fashion to kind of correct for the fact that it's a misnomer. If they just called hepatomas hepatocarcinomas, which sometimes they do, then you wouldn't have to use the word malignant in front of it. But almost all of these things, very few people will say, "Oh, he had a melanoma." They always say, "He had a malignant melanoma." Okay, let's move on and let's show you an example of a tumor composed of cells from more than one germ layer. Well, you see this here? That's hair, isn't it? That was from the inside of the cyst. And you also see that Maybe there's some connective tissue, like in the wall. And look, in addition, you have a tooth in there. This was from a woman's ovary. You take an x-ray of the woman's pelvis and you see a tooth. Or sometimes you can see brain tissue inside it. These are eye tissue. Almost any type of tissue you can see. Smooth muscle tissue, bone, cartilage. And generally, the more the tissue looks like classically normal, mature tissue, the more likely it is to be benign. And the fact is, in the ovary, most of these teratomas are benign. Most of them have sebaceous material. Most of them have hair. Some of them have more exotic things like tooth, maybe thyroid, glia, smooth muscle. So that's an example of a tumor comprised of cells from more than one germ layer. Teratoma of the ovary. Look, here's that same thing. And if you say hair and you see sebaceous material, you say, well, that doesn't prove there's connective tissue except for the tooth, right? Well, look, it also has bone. This is typical bone tissue. Here we got bone marrow as well. You see, 50% cellular, a heterogeneous mixture of hematopoietic cells. You can see something here that looks like it might have a columnar lining to it. You could see some here, cells here that are glandular and they look like they might be secreting mucin. So this is a typical teratoma. And let me tell you something. If every single thing in this teratoma, no matter where you take the slide from, looks like it's mature bone or mature mucus glands or mature columnar epithelium or mature marrow or mature cartilage, then most likely it's going to be benign. Okay, let's keep moving on. We're doing pretty well here. And let's look at another dermoid cyst. This is the most typical type of teratoma. And here you also have a squamous lining. You see almost a stratum corneum there. You could almost see some maturation from a basal layer towards a more flattened squamous surface layer. You can see sebaceous glands. You can see smooth muscle. You can even see myoepithelial cells, probably very small at the periphery of these sebaceous glands. You can see connective tissue. So this is a classical dermoid cyst of the ovary. It's a really, really spectacular picture again. I want to remind you, this was not Googled when I put in the term dermoid cyst. This thing was taken from the University of Iowa virtual microscope and blown up to high power. And I made a dazzling picture of it for demonstrating to you. Okay, I think we're generally in a good situation here. You notice we're not going very fast because the things that we're talking about here, you really have to kind of know like the back of your hand. You have to really know this forever. So we're going at a nice pace. Now we're going to go into a slightly different topic. And do you remember when we had the epics, the sagas of inflammation and all the different things that happened in a linear fashion? Well, it's also true with neoplasms as well. You have to have something occurring in the cell or around the cell or in the cells that regulate the cell. And that's referred to as transformation. So to go to a target cell, usually a sort of a stem cell within tissue, into a malignant or benign tumor cell is referred to as transformation. If it's malignant, it's called malignant transformation. And then those transformed cells have to grow. And it could grow for years, 2-3 years, before it's even 1 centimeter in size. That's the general rule. And then, somewhere along the line, after it's many cells, perhaps millions or billions, it invades. It has to penetrate. It has to breach. It has to break that basement membrane. If it's a epithelial cell, all epithelial cells are on basement membranes or basal laminas. It has to invade that. And once it invades it, once it infiltrates it, infiltration and invasion are words that are used interchangeably. They mean exactly the same thing. then it's potentially metastasizable, because now it's not on one side of that protected basement membrane. Now it's within the connective tissue, where there are lymphatics, where there are veins, where there are arteries. So any invasive tumor is potentially or theoretically metastasizable. And this is the right order. It would be inconceivable that you would ever not get this order correct. If I had to ask questions, I would just put these four things mix them up and say, show me the correct order. Okay? Let's also talk about the differentiation of tumors. And differentiation is a topic, it's a term that really pathologists literally spend their whole life thinking about differentiation. When you think about it, all we are differentiated zygotes, aren't we? You know, we had one single cell, things happening to that cell, multiplication, changing the cell, differentiating into connective tissue structures, into epithelial structures, and making us entirely what we are today. Well, tumors do that too. If you have a tumor, whether it's benign or malignant, and you look at the cells on that tumor, and you say, oh my God, these cells look exactly like the normal tissue that the tumor came from. You know, let's say you take a look at a piece of normal thyroid tissue, and you say, oh, well, this is just normal thyroid. Well, what if somebody said to you, well, this normal thyroid that you just called normal thyroid was just scraped out of somebody's bone, or just scraped out of somebody's liver? Then you say, well, it's cancer, but it just happens to look well differentiated, doesn't it? A poorly differentiated neoplasm is composed of cells that do not look like the organ it came from. Very simple. A well differentiated looks like the cells it came from. A poorly differentiated does not look like the cells it came from. And I got to ask this question. I'm sorry for bugging you again. What kind of tumor do you think is worse? A well differentiated or a poorly differentiated? Absolutely right. Somebody gave me the real correct answer, and they said undifferentiated, because undifferentiated is even worse than a poorly differentiated. Okay, and that's our third category. Let's say that the tumor cells in question excuse me, do not look at all like the cells that they came from. Up here they looked like them almost identically. Up here they looked like them a little bit. But up here the tumor cells don't look like them at all. Then you would call that undifferentiated. Now, if you don't even know, if they don't look like the cells at all, then how do you even know that that tumor is arising from that area? Good question. Could it be metastatic rather than primary? Absolutely. So here's the general rule, and we said it, we'll say it again. Benign tumors are all well differentiated, but malignant tumors can be well, medium, poor, or undifferentiated. And as you might guess, the more undifferentiated tumor is, the more it's going to behave badly. Here, I took a picture here. This is not from Robbins, okay? This is something I Googled. And I just want to say something. If you were to be walking down the streets in New York, and you saw these guys, they look pretty bad, don't they? Now, let me ask you this. They look bad, so do you think they're probably going to behave bad as well? That's the whole principle of diagnostic tumor pathology. If cells look bad, they're probably going to behave bad. And what does it mean to look bad? Well, to look bad means it doesn't look at all like the cells that they supposedly arose from. Now, let's say that you're in Salt Lake City because you're afraid of these guys, and now you go to Salt Lake City because you heard there's a lot of, holy Mormons there. So here you are, you're in Salt Lake City now, and you see these people up on the stairs, and they're, dressed nicely, and they're all singing hallelujah. And the question is, these people look pretty good, They look like they're nice, holy people. So they're probably going to behave good. These people will probably not mug you, okay? So if the cell look good, it means they're probably going to behave good. And looking good means looking a lot like the cells they supposedly arose from, or well differentiated. Now what if I was to tell you that this is a uterus, and it's opened up, and all these white little nodules are tumors of the cells that comprise 99% of the uterus, smooth muscle. They're also called leiomyomas. By the way, if they were malignant, would they be called leiomyosarcoma? Yes. Well, let's say that you went to your microscope here, and here I have something in the corner for you, and I'll make it a little bit bigger. Let's say you went to your microscope and you were told, this is normal, smooth muscle. Look, here the fibers are cut longitudinally so they look a little spindly. Oh, maybe this one here was cut a little bit more on end, so it doesn't look like a cigar anymore. It looks like something round. And of course the fibers don't have striation, so you know it's not striated muscle or cardiac muscle. Okay, now then we took that set of normal smooth muscle, which is right here, and now we're going to take a section of one of these leiomyomas. And let me ask you this. Do these spindly cells look exactly like normal, smooth muscle cells? That was a question I want you to answer. And somebody said no, but mostly they do. They kind of look spindly and the same. I'm glad there's a difference of opinion here, but for the most part, if you were to show a pathologist a high-power view of a leiomyoma and say, is this normal, smooth muscle? In all honesty, most likely they would say yes, except it is normal, smooth muscle forming a tumor. And here's a little tumor nodule as well, only it's like low-power microscopic. Okay, that's the general rule. Let's talk about malignancies now. Malignancy means cancer. Cancer means anaplasia. All three of those words are exactly the same. Anaplasia means cancer. Anaplasia is the process of cells growing in such a way that is not only unregulated but invasive and potentially metastasizable. Remember in day one we learned about the Plasia brothers, and we said that anaplasia was one of them, and it means cancer. And sometimes the word frank, F-R-A-N-K, in the literature is put before the word anaplasia. It means not only cancer but obvious cancer, or frank anaplasia. Now, cancer cells, anaplastic cells, malignant cells have several features which are very, very, very common no matter where the cancer arises from. And I'm going to tell you the big three, or actually there's 4 or 5, but even if you only remember 2, that would be okay, because any pathology reports that you read from your patient will probably have the word hyperchromasia and pleomorphism on it, no matter what the cancer is. And pleomorphism means not the cell, but the nuclei are not uniform. Some are big, some are little, some look like normal ovals, some might look like 4-leaf clovers, but there's a lot of variation in size and shape. That's pleomorphism. Part of the pleo means that some of the cells are really big too. And in general, cancer cells or cancer cell nuclei are bigger than normal cells. Now, what does hyperchromasia mean? Well, we have 2 stains in the lab that are used almost always for all tissues, hematoxylin and eosin. And hematoxylin is a dark bluer stain. And because there is generally, might not be saying it fairly, but the more nucleic acid, nuclear proteins you have in a nucleus, the darker the cell's going to be. Why? Because the nucleus takes up the hematoxylin and the cytoplasm takes up the eosin. So the larger that nuclear is and the more nuclear material, ultimately nucleic acids and histones, the darker, the bluer the cell is going to be. Also, especially in cytology, a malignant cell will have a bigger nucleus with respect to the rest of the cytoplasm. So it's what they call a nuclear cytoplasmic ratio. If you have a cell and the nuclear gets bigger but the cytoplasm stays the same, then you have a high nuclear cytoplasmic ratio. Another thing is, if you remember, when you look at cells, the chromatin within a nucleus is supposed to be dispersed pretty uniformly. Sometimes it's a little clumped near the edge, like we saw with plasma cells or lymphocytes, but generally in tumor cells there's significant chromatin clumping. There's so much clumping of chromatin sometimes you can't even tell whether something is a clump of protein or whether it's an extra nucleolus. And that goes for another feature. Sometimes malignant cells have large prominent nucleoli. Sometimes they have multiple nucleoli. Sometimes they don't have extra nucleoli, but the chromatin clumping is so bad it looks like they have extra nucleoli. Another thing to remember is that the faster that tissue grows in general, the more likely you are to see a mitotic figure within the tissue. So cancers have more mitotic figures, mitoses, chromosomes strung out, like an anaphase and metaphase. And sometimes, like with this example that we saw here with the smooth muscle, sometimes the only way you could tell the difference whether this is a leiomyoma or a leiomyosarcoma is you have to count the mitoses in multiple, at least 10 or 50 or 30 high-power fields. And if it has a certain number of mitoses, then it's malignant. Now, if you look at this, in all honesty, I don't think you could see a single mitotic figure. Maybe one, I don't know. Probably one mitosis, or usually you have none. But generally, with all connective tissue tumors, the number of cells that happen to be in mitotic division often determine whether it's benign or malignant, or number two, how malignant it's going to be. So here, let me ask you this question. It's very, very important again. That's why I keep popping out the window here. Let me ask you this. Let's say that you had two leiomyosarcomas. One of them had 2 mitoses per high power field, and one of them had 7 mitoses per high power field. Which one is going to behave worse? Of course, the more mitoses, the more malignant. That's a good general rule as well. Okay, let's look at all of these examples now. Would you say that a lot of these nuclei are a lot bigger than they normally are? Yeah, that's pleomorphism. They're not all round, are they? Some of them look like they're bumpy. Some of them look like horseshoes. Some of them look like, they're fragmented, like somebody stepped on the nucleus. Some of them almost look like giant cells with multiple nuclei. So some of the nuclei are a lot darker. That's hyperchromasia. All of the nuclei in general don't look uniform with respect to each other. That's pleomorphism. Now, I don't really see a good mitotic figure here, but maybe this is over here. These could very easily be thick, abnormal chromosomes. Now, what do you think this is over here? I'm going to pop this out again, and I'm going to ask you once again, what do you think this precise little thing is right here at the tip of my arrow? You see that? Anybody want to stick their neck out and guess? Nobody wants to guess. Yeah, you're right. It is a prominent nucleolus. But also remember that there could be so much chromatin clumping, like you see here, it might look like there's multiple nucleoli. So, let me ask you this question, and you don't have to worry. I don't care what you say. You can also see the diagnosis underneath. But do you think this is a tumor that a pathologist might call really bad? Yes. And probably because it has the two features that we talked about stand out like a sore thumb: hyperchromasia and pleomorphism. And you'll almost always see those two words in almost every one of your patients' cancer reports they get back from the pathologist. Okay, let's talk about this little concept now. Let's see how we're doing with time. Well, we're already past the hour, so you know what we're going to do? We're going to take a break, and then we'll talk about dysplasia, or the process of transition from normal regulated cell growth into neoplasia. So what we're going to do is just take a few songs and see you back in 10 minutes. During that time, I'll do my normal things, and I'll also be able to read your chat questions. And this is our next song.
I love the colorful clothes she wears, and the way the sunlight plays upon her hair. I hear the sound of a gentle wind on the wind that lifts her perfume through the air. I'm picking up good vibrations, she's giving me excitations. I'm picking up good vibrations, she's giving me excitations. Good vibrations, good vibrations. She's somehow closer now. Softly smile, I know she must be kind. In her eyes, she goes with me to a blossom room. I'm picking up good vibrations, she's giving me excitations. I'm picking up good vibrations, she's giving me excitations. Good vibrations, good vibrations. Gotta keep those lovely vibrations happening with her. Gotta keep those lovely vibrations happening with her. Gotta keep those lovely vibrations. Good I met you, I'll break 1,000 more, baby, before I am through. I wanna be yours, pretty baby, yours and yours alone. I'm here to tell you, honey, that I'm bad to the bone, bad to the bone, bad, bad to the bone. Woman beg, and I make a good woman steal. I make an old woman blush, and I make a young girl squeal. I wanna be yours, pretty baby, yours and yours alone. I'm here to tell you, honey, that I'm bad to the bone. Bad, bad, bad to the bone. They all stay satisfied. I want to tell you, pretty baby, when I see I make my own, and I'm here to tell you, honey, that I'm bad to the bone, bad to the bone, bad, bad, bad to the bone. Yeah, you are my fire, the one desire, believe when I say I want it that way. But we are two worlds apart, can't reach to your heart when you say that I want it that way. Tell me why ain't nothing but a party. Tell me why
for hanging in there. As always, I did my usual things. I got my new infusion of caffeine, took out the doggy, went to the bathroom. You know, I got a really loud toilet downstairs. I'd be really embarrassed if you could hear it when it flushes, but just tell me you don't hear it and you'll make me feel better. I was looking at some of the questions that we had during the break, and there's 3 of them I want to address because they're all really good questions. Well, somebody says, what is a histiocytoma? That's an interesting question. Histiocytoma, you would think, would be a tumor of a histiocyte. The problem is, nobody's ever really determined what exactly a histiocyte is. And very often, I tell you that the pathologists call macrophages histiocytes. So technically, a histiocytoma is a proliferation of histiocytes. The problem is, they're not the usual type of macrophages, and they're spindly little cells, and they're very often found in soft tissue and in skin. So a lot of the things that are called histiocytes in skin and soft tissues are actually more like fibromas. And it was not an easy question, but I hope I answered it properly. Somebody also said they saw a lot of mitoses, and we said that whenever we see mitoses, that's bad. Now, let's say that a mitosis normally divides. If you remember from 3rd grade biology, let's say a mitosis normally divides in 2 directions, North Pole and the South Pole. Remember that? Well, did you ever hear of a tripolar mitosis rather than a bipolar mitosis? Or let's say that a mitosis goes in 3 directions rather than 2. A tripolar or a multipolar mitosis is almost always the hallmark of a malignant cell. And even though the things that we showed you today there's not one single thing cellularly that absolutely proves that any particular cell is a malignant cell. But when you see a mitosis that's going in more than 2 directions, it's almost always malignant. Now, a 3rd question was, can you often confuse a virally infected cell and changes in the nucleus from viral infections with cancer cells? And the answer is yes! It happens all the time. Very often, atypical cells, especially things like lymphocytes, are due to viral infections. Now, you want to know the really cool thing about that? Very often, the effects that viruses have on nuclei may very well lead to neoplasms, but they may not be. So, yeah, they're confused, but sometimes they're the same. And that leads us into the topic now of what we call dysplasia. And dysplasia, as you could see here on the PowerPoint, as of right now, means abnormal growth. So, you know, surgeons like to believe that there's 2 kinds of cells. Benign cells, which they don't cut out, and malignant cells, which they do cut out. That's a very nice, simple, mechanical way of thinking, and God bless them for thinking that way, especially the ortho guys. However, there is a whole range of changes going on inside the cell leading up to a malignancy, which may not ever even develop into a malignancy or an infiltrating malignancy. That's called dysplasia. And a dysplastic cell is a cell that is undergoing a transformation into a potential neoplasm or malignant neoplasm. Now, when we just told you and showed you all of the features of malignancy, like pleomorphism, hyperchromasia, abnormal mitoses, these may be present in dysplastic cells, but the dysplasia may never develop into a full-blown infiltrative malignancy. So when you see an epithelial lining and the nuclei are darker, they're bigger, they're lumpier, you say this is dysplasia. If those same cells now have breached the basement membrane and you see them below the basement membrane, you could say these same cells, which look dysplastic, are now part of an infiltrating malignancy. You know, there's a lot of places where you see dysplasia. Technically, you can see it any place. But in regular practice, you know, the uterine cervix is a place where we talk about dysplasia the most, because we do pap smears, we see dysplastic cells, we do biopsies, we do leaps, we do hysterectomies. And sometimes you can see that that squamous mucosa is not always normal and orderly like you normally see in a non-keratinized stratified squamous epithelium. Sometimes the colon polyps, we showed you a couple colon polyps already, and the glands look pretty orderly, but in one area, we saw an area where there were back-to-back or other dark pleomorphic hyperchromatic features of malignancy. Sometimes the dysplasia, as it is seen under a microscope, is called either a little bit of dysplasia or low grade, or a lot of dysplasia, or high grade, or severe dysplasia. And very often, whether you call something low grade or high grade might depend on whether that patient is just followed and repeated, you know, several months later, or whether some immediate surgical or other interventional process should be done. And remember, not all dysplasias develop into malignancy. There's so many studies showing very dysplastic epithelium, especially in the cervix, which completely spontaneously resolve. Now, from a medical legal point of view, if you see something that often goes into malignancy but sometimes doesn't, how are you going to handle that patient? Are you going to say, well, you know, this might be cancer, we better do something about it? Or do you say, well, you know, 22% of them go away, so we're not going to do anything? Of course you're not going to do that either. Now, if the dysplasia is high grade, and once again, I'm using the female genital tract as the example, and Dr. Crum, who gave us a beautiful webinar this week at GoPath, went into these in great depth. But if you have a high grade dysplasia, the philosophical question is, could this be carcinoma in situ? And for many, many generations, there was great agony and gnashing of teeth as to whether something was highly dysplastic versus carcinoma that just hasn't infiltrated the basement membrane yet. Well, nowadays, most of the newer classification systems kind of put high-grade dysplasia in the same category as carcinoma in situ. Now, if you call something carcinoma in situ, you are generally going to say that that thing will eventually infiltrate. In a very small percentage of the times it might, but almost all of the carcinomas in situ will, with time and with influences, and with all of these things we'll talk about under malignant transformation, they will infiltrate. Okay, so what is this? Well, it is a cervix, and you can see there's an endocervical gland. It's nice, it's columnar. It has simple columnar epithelium. And then you see the squamous overlying. Now, I took the freedom of going to a great microscope to show you that this is a normal squamous epithelium. It's a normal maturation pattern of normal surface cervical, ectocervical lining of squamous, stratified squamous mucosa. The cells at the basement membrane look sort of columnar because they are, and then the cells in the middle look sort of cuboidal because there are, and then the cells at the surface are flat and they look truly squamous, and they are squamous because they are. So even though this is called stratified squamous mucosa, it has both columnar as well as cuboidal cells. But remember, stratified epithelium is always called by its most superficial layer. That's totally normal. Look at the maturation pattern as you go from the base to the surface. The ratio between the height and the width becomes smaller. The nuclei become smaller. and the cytoplasm becomes flatter. Okay, that's normal maturation pattern. Okay, now here's something I wanted to show you also. This shows kind of a maturation pattern. They do get a little bit smaller, but look at, you have a precise squamous epithelium here, and then this is the very, very last squamous cell before you get into the columnar cells. This is a squamo-columnar junction, precisely, microscopically. Remember, you also have them in the anorectal junction. You also have them in the gastroesophageal junction. This is a very, very active growth center, and that's where most of the carcinomas of the cervix arise. But that's not my point. My point is to show you that in dysplasia of just about any place, especially epithelial dysplasia, you don't have that general normal maturation pattern. There are too many cells here in the middle that still have big, dark nuclei. Furthermore, I think you could say there's some atypia. And yeah, you do see some maturation towards flatter cells, but it's not totally normal like you see here. So could this epithelium be subject to the factors that will or might eventually turn it into a cancer? And the answer is yes, because dysplasia is not only a microscopic appearance, it's also a process called transformation into malignancy. And that malignancy may take many years. It may take just a few months. It often takes years. Now, keep your eye on this portion. This is what we called dysplastic maturation pattern. There's still a little bit of maturation from the cells that have the larger nuclei to the flat cells on top that have the smaller nuclei. But look, here's another cervix now. Now the question is, this is severe dysplasia. Why? Because the cells exactly at the base of this epithelium look almost identical to the cells at the surface. This is severe dysplasia. Now, if you want to say, well, you know, there's still a few little flat cells up here, we can't really call it carcinoma in situ, but we could say it's a lot more severe than the last one we saw. So, this is the point. Whenever you see something that is severely dysplastic, you might be tempted to call it carcinoma in situ. In other words, this is cancer. It just hasn't infiltrated through this basement membrane yet. And furthermore, here's a normal columnar endocervical gland as well. So, if you think that pathologists for generations have banged their heads against the wall, agonizing whether they should call something severe dysplasia, or put a word on that pathology report that might prevent them from getting insurance forever, in other words, carcinoma, even if it's only in situ, they don't have to bang their heads against the wall anymore, because as we'll see that in glandular structures as well as epithelial structures throughout the female genital tract, whether you're in the vulva or the vagina or even the fallopian tube or even the endometrium, there is now the general rule is that if something is severely dysplastic but it hasn't infiltrated, you're probably going to call that carcinoma in situ. And if it's a gland, you call it adenocarcinoma in situ. Okay, let's talk about the rate of growth now of tumors. Let's say theoretically something happens and you have your first official cancer cell. And that official cancer cell is going to start doubling and multiplying. Some of the cells won't multiply, but there is the replicative pool which multiplies. Now, it takes 30 doublings of that theoretical cancer cell. Remember, that's 2 to the 30th power. 2, 4, 8, 16, 32, 64. You do that 30 times, and now you have what looks like 1 billion cells. And that's only going to be 1 gram. And if that gram is about the same tissue density as water, it's going to be about 1 centimeter in diameter. So it takes generally months to years overall for a tumor cell that's absolutely malignant to keep multiplying to be only 1 centimeter in diameter. Isn't that pretty scary when you think that little tumor didn't pop up yesterday, but something's been going on often for years? Now, if you then have that theoretical 1 gram tumor, which most likely is going to be localized and not metastatic, but it could metastasize even before then. If you have that 1 gram, 1 centimeter tumor, and it goes only 10 more doublings, you now have 1 kilogram. And a 1 kilogram tumor burden is generally regarded as lethal. So when you see a large lung cancer or a large colon cancer and all of its metastases, you do the autopsy, you take out all the tumors, you put them on a scale, it's 1 kilogram. Most likely that's why you're doing the autopsy. That's a good general rule, but once again there's a lot of exceptions to that rule. And as you know, with chemo, tumors can shrink. Okay, and also remember that not every cell in the tumor can multiply. And even in the pretty rapidly growing tumors, only a relatively small fraction are in that replicative pool, maybe only 20%. The cells which probably are the most multiplicative are the tumor stem cells. And remember, when you see a tumor that looks a lot like the cell that it came from, the tumor probably did not arise from the mature cell. It probably arose from a cell that gives rise to those other cells. So tumor stem cells are the most replicative of all. And don't forget, in the tumor itself, some of those cells have died. Some will die. Some will undergo apoptosis. And some will mature to the point that they look like normal tissue, but they won't be able to multiply. These are all possibilities. And of course, in terms of the development of new chemotherapeutic drugs, you generally want to take those cells which can multiply. You don't care about the cells that can't multiply. You want to take that small percentage and take your chemo over there. Because even if that's a small fraction of the tumor, the rest of those cells aren't going to grow. So that's what it means by implications for therapy. Here's another little diagram, and it's going to be almost identical to the next diagram. I like this. It shows a clonal cell, theoretically a single cell, in this process of what we'll talk about as malignant transformation, undergoing 30 doublings, and now it's only 1 centimeter. And the reason why I say centimeter is if you go to a radiologist and you say, well, you know, what if this patient has a 1 centimeter lesion of the lung or the liver or the pancreas or the spleen or, you know, the adrenal? You say, can you see that? And they'll probably tell you that when they use CT or MRI, the general rule is they're not going to see something that's only a couple of millimeters big. Most likely they can only detect this after it's undergone, you know, 30 doublings, or it's about 1 centimeter. Sometimes it's even more than 1 centimeter. So here's your normal cell. It undergoes malignant transformation. The red guys are the tumor cells. There's a lot of variance because they differentiate or they die, or they theoretically can be invasive cells. Some of these cells, the blue ones, are invasive. The red ones can theoretically metastasize. The purple ones, actually I don't know what the purple ones do. They're just more variants. And these light blue ones are non-antigenic. What does that mean? Well, they don't have the proper antigens on their surface to be recognized by the immune system to be killed. So these are successful cells in terms of malignancy too, aren't they? And then you go 9 more doublings, usually a few more years, and you have maybe something that could be pretty close to a kilogram mass if you add up the tumor and all its metastases as well. Here's another diagram. I like this one better. This is your proliferative pool, or what we call the replicative pool. The cells that technically can multiply. In other words, the cell that's been transformed into malignant, it's multiplying. You know, sons, daughters, granddaughters, great-granddaughters, and sons. And then it enters also this non-replicative or non-proliferative pool, in which some of them have died, some of them have differentiated into cells which will not multiply anymore, which of course most differentiated cells of the body are as well. And some of them have just gone into this G0 phase, or this phase of the cell cycle in which they just don't multiply anymore. They're just chilling for the rest of their life. Okay, let's talk about more malignant features and often compare them to benign features. We've already seen a lot of the cellular features under the microscope, but the main feature that makes a tumor malignant has nothing to do with the way the cell looks like. The main feature which makes a tumor malignant is a question that's been put on every single pathology board exam since the beginning of time. And it's this concept of invasion. If a tumor cell can invade, it's malignant. It doesn't matter what it looks like, whether it looks like good or bad or undifferentiated. If it invades, it's cancer. If the tumor is, if it's an epithelial tumor and is confined to a basement membrane and it breaches that basement membrane, it invades it, it destroys it, it dissolves it, it proteolyzes it, it's malignant. If the tumor is sort of well defined within a capsule, but then it breaches that capsule, like in the thyroid, the main feature that differentiates benign from malignant thyroid tumors sometimes is whether the tumor has invaded the capsule. So when you look at a thyroid tumor, don't look at the cells, look at the capsule. And also metastases. If a tumor is metastasized, you don't have to sit there and wonder if it's benign or malignant by looking at the nucleoli, right? You know that a tumor that metastasizes is malignant. Oh, there's probably a few little nitpickers there that could say, well, I know of a couple benign tumors that can metastasize. And I'll say, shut up, I'll talk about those later. And metastasis is an unequivocal sign of malignancy. It could metastasize through lymphatics, through blood vessels, through body cavities, and that's what a metastasis is. Let's take a non-specific tumor. Let's say you didn't know this was breast. It doesn't matter if it's breast, but you know this round, lumpy, nodular thing is a tumor. Now let me ask you a question. Does the tumor look pretty well defined? In fact, I'll go a step further. Let's say this tumor is that little yellow thing here, but you look at it grossly and even microscopically, and you see there's a little white rim of connective tissue surrounding that tumor, or something that was a capsule, so to speak. So the question is this a benign or malignant tumor? I need the answer. Of course it's benign. And it happens to be the most common benign tumor of the breast of young women. This is a fibroadenoma. And look, here it is microscopically. You could see the capsule, can't you? Sometimes it doesn't look like a specific capsule with the epithelial lining, but it's just kind of a compressed amount of fibrous tissue and fat separating that tumor on the right from the normal breast tissue on the left. And you know this is normal breast tissue on the left because you could see some acini here, and you see a lobule over here. Now in this particular tumor, is composed of both glands as well as fibrous connective tissue. So, do you think the word fibroadenoma is a perfectly appropriate name? Of course it is. That is the most common benign tumor of young women. A young woman has a breast lump and she's worried about it, and it's well defined, and you can see on a mammogram it's well defined. She goes and has surgery anyway, and she's really, really worried. Well, chances are 9 out of 10 is going to be a fibroadenoma. Here's another breast tumor. And let me ask you the same question. Let's say this was the tumor here, and this is the surrounding fat. Oh, somebody got the answer already. No fair. Is this white tumor very well delineated from the surrounding fat, or does it kind of blend in like claws of a crab, for example? Yeah, it's infiltrative, or invasive, or infiltrating. It doesn't matter what you call it. So, even before you put it under the microscope, let me ask you the question. Is this breast tumor benign or malignant? Oh yeah, you all know it's malignant. In fact, hell, why should we even put it under the microscope? Well, the reason why you put it under the microscope is because you look at the cells and you then can tell the doctor how malignant it is. And here it is under the microscope. And remember, in the fibroadenoma, like we saw here, we saw a nice interface between the tumor and the connective tissue. But look, here's connective tissue up here, and here's glandular tissue down here. And look at all these little nests of epithelial cells, which are just kind of strewn off into the stroma or into the connective tissue. You can't put your finger on the tumor and say, well, this is the edge of the tumor, because look, these are little nests. Do I want to show you something else? Yes, I do. This is much more the same thing. And at this point, it's very, very important that I explain to you what I did in China to some of the students there. And, you know, their English was not perfect, but they were asking me to show them cancer cells because they worked in a molecular lab, and they often had to find those cells, you know, to do tests on them. So we were like on the 9th floor of a big building in Shanghai, and I told them to walk over to the window. And I said, take a look at all those trees down there. I says, there's about 100 different trees, aren't there? I said, they're all different, aren't they? They all look different, but they all still look like trees because they're growing like trees. I said, the same is true with human tumors and human tissue. If this was a breast, you could recognize normal growth. Look, here is a lobule. This is going to look different from a million other lobules you see in the breast, but you can still recognize it as a lobule. Whereas look, what about these glands? They're not growing like any lobule I've ever seen. They're growing haphazardly and in an inorganized fashion. And all the things we said about cancer from a molecular point of view, the loss of regulation, we are now seeing with our own 2 eyeballs. They're growing haphazardly. And that's even if you don't look at the nuclei and see that they're big and dark and hyperchromatic. Because they may not be big and dark and hyperchromatic with a lot of mitoses and a lot of nucleoli. Look at how they grow. And that's the mistake a lot of residents make and also a lot of students make. They think, well, if I want to look at this as being cancer, I better get and look at those nuclei and see if they're lumpy and bumpy and dark. And I go, whoa! I go, back off. I say, look at the growth pattern. Does this look like any normal breast lobule you've ever seen? Or are these cells just kind of streaming off into the connective tissue? That's how you diagnose cancer. Cancer is a low-power diagnosis, even though it's nice to see the nuclear features on high power. Now, here's the next question. Let's say you were doing an autopsy and you were blind. Okay, now if you're blind and you're doing an autopsy, you better be careful because you might cut yourself. But let's say you got the liver out, or your path assistant got the liver out, and they start slicing it for you, like in a deli shop. and you're still blind, and you feel the surface of the liver. Now, parts of the liver are nice and smooth, but parts are nodular and lumpy, and some are really big nodules and some are smaller nodules. Now, here's the question. If you were blind, would you still know these were metastases? Absolutely. How do you know it's not cirrhosis? Because in cirrhosis, the whole liver is nodular, and they're often diffusely small nodules, almost non-palpable, and sometimes not even visible nodules. They're micronodules. But in metastasis, the liver surface feels smooth in many areas, even if it's widely involved by metastases, and the nodules are big. Okay, that's another gross appearance of a tumor. Here's something in microscopic now. Let's say that you had enough confidence now to say, well, I can see these are glands, and they're not growing like any normal gland should be growing. They're growing haphazardly. I don't even care about the damn nucleoli and my pleomorphism. I know this is adenocarcinoma. Okay, well, let me just ask you this offhand. How many of you kind of instantly knew this was adenocarcinoma? You could either say yes or no. I don't care. I see a no. I see 2 yeses. I see about 50-50. There's a little more yeses, but what can you also say about this adenocarcinoma? You can say, well, whoa, yeah, there's fibrosis, all right, but what are these cells at the periphery, like there and there and there? Yeah, these are lymphoid follicles. So could this be an adenocarcinoma that has widely replaced a lymph node or metastasized to a lymph node? And of course the answer is yes. Now, could it also be a tumor that hasn't metastasized, but a bunch of lymphoid cells are reacting to it? And of course the answer is yes. So here's the question. How do you know whether this is just a regular old adenocarcinoma of anything with a lymphoid army of lymphocytes trying to fight it, some of which have nice germinal centers like you see there, or whether this was metastasis to a lymph node? Well, you would probably have to look at the rest of it and see if you could see like follicles towards the outside and maybe a subcapsular sinus and blah, 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 blah. Okay, that's the answer to the question. Let's talk about lymph node metastasis now. And remember, this is mostly true with carcinomas, because although sarcomas metastasize to lymph nodes, usually they metastasize to blood vessels before they metastasize to lymph nodes. And they may not metastasize to lymph nodes at all. On the other hand, carcinomas usually metastasize to lymph nodes before they metastasize to blood vessels. So that's really a good thing to remember as well. So what happens if you see tumor cells within a lymph node? And of course, I'm a pathologist. I spend half of my life picking out little lymph nodes, trying to be tedious and patient, and getting a bunch of lymph nodes and seeing whether there's cancer. Because the general rule is, everything else being equal, if the tumor has metastasized to lymph nodes, that's not good. If the tumor hasn't metastasized to a lymph node, even if it's a pretty good sized tumor, chances are that patient's going to be cured. So if you do a real painstaking, tedious job of looking at all the lymph nodes in your breast or in your colon or in your lung, and you work there for hours and you're sweating, and you see that there are no metastasis to the many lymph nodes you find, guess what? You saved that patient's life. You saved that patient's life probably just as much as the surgeon did. And in the old days, if you had lymph node metastasis, they would do a more radical procedure called a Halsted radical mastectomy. Now, they don't tend to do these at all now. And usually now what they do is usually inject an isotope or a dye into the region of the tumor and then see if they could find the first lymph node that picks up that radioactive tracer. And that's called the sentinel lymph node. And you can often see that when you scan the patient after you inject the dye near the melanoma or near the breast tumor. And it's called the sentinel lymph nodes because it's the watchdog lymph node. It's the first lymph node to pick up a theoretical tumor metastasis. So if you just take out one lymph node and you slice the hell out of it and you look at it very, very carefully, you see it is truly negative. You might even do some stains to see if some of those cells within the lymph node have epithelial markers. Because should a normal lymph node have epithelium in it? Absolutely not. So if you only see a couple of cells that are just with epithelial markers in a lymph node in the proximity of a malignancy, is that probably a metastasis? And the answer is yes. And that puts the patient into a whole other category, doesn't it? And also, when you stage that patient, you have to talk about the extent of the lymph node involvement, whether it's negative, whether it's a little, or whether it's a lot. The so-called TNM system, which we're going to be getting into later, and the N stands for lymph node. Another thing to remember is that a tumor with a positive lymph node or more is more likely to show a worser prognosis, might be more necessary to treat more aggressively with chemo, or adjuvant chemotherapy, which is being done a lot now, even in patients that have not had positive lymph nodes. They may give a milder form of chemotherapy, and that has been shown to prevent recurrence as well. Needless to say, in lymph node negative malignancies, the patient usually lives. I hate to generalize, but that's the general rule. Let's look at benign versus malignant features now of any tumor. And we're going to say benign versus malignant. And I think these are all very, very logical, but they have to be discussed in detail anyway. Well, you have a rate of growth. Benigns have a slower rate of growth, and that could be evidenced by fewer or maybe even no mitoses, plus the mitoses look normal. They're not tripolar. They don't look like the Mercedes-Benz sign going off in 3 different directions. Whereas a malignant tumor can have a fast growth. You can see more mitoses than in a benign tumor, and some of those mitoses might be abnormal. This is almost goes without saying. A benign tumor is most likely going to look almost identical to the tissue from which it originated. If it looks like normal thyroid, it's probably well differentiated. If it looks like normal colon, it's probably benign. If it looks like normal pancreas, it's probably benign. Now, a malignant tumor, even though it may be well differentiated and in many areas resemble the tissue from which it originated, there's going to be usually a lot of areas where the cells just don't look like it at all. And sometimes the whole thing doesn't look like it at all, and that's what we call poorly differentiated or undifferentiated. In some of those cases, you just may have to do antigenic stains to make sure it really did come from that tissue as well. Now, here's the big thing, and it is the single thing that differentiates benign from malignant tumors. It's invasion, otherwise known as infiltration. Benign tumors do not invade. They do not infiltrate beyond the basement membrane or beyond the capsule, whereas malignant tumors do by definition. Cancer, malignancy, means infiltrative. A benign tumor does not metastasize. Almost any malignant tumor can metastasize. Sometimes they'll talk about endometriosis. You wouldn't really call that a tumor. It's more like ectopic endometrial glands. But if you see endometrial glands which are normal looking in the umbilical cord or the bladder or the surface of the liver or the bowel, you may kind of think of that as a benign thing that has metastasized, or most likely it's just ectopic. Same thing with pancreas. If you see ectopic pancreas, It's not a benign tumor of the pancreas that metastasized. It's just tissue that may have been there and stayed there during the embryologic development. Okay, we've done really, really well, and we're about halfway done with the PowerPoints. And this was the fun part. This is the actually my most enjoyable class is the one on cancer, because that's what I've done my whole life. So it's a good time to take a nice big pat on the back for yourself and know that you've gotten a lot of the basics down. We'll go more into things like statistics and biochemistry and stuff like that on the next session. And I think this is a good time to stop. I'm going to open up the question box and see if anybody has any comments. And if that doesn't work, then I'm going to look to see if anybody has their hands raised. I have a very large number of people again today. There's always twice as many in the second half than in the first. You have no idea how much that thrills me. I have nothing more to say by way of announcements. So here's what I'm going to do. I'm going to close this for now. First I'm going to save it, because I probably made some typo changes. And as soon as that's done being saved and the hourglass goes away, I'm just going to close it. Whoops. It's still saving it. So I think I'll be able to close it now. If not, yeah, we're done with that. I'm going to go to the attendance list and see if anybody has their hands raised, because it's 10:58. We got a couple minutes for questions before you hear my inspirational song. And if I don't see many questions, I'm going to feel good that I explained everything properly. Oh, thank God, no question. Whoops, that's the wrong box. Let's do this one. Okay, whoops, that's not what I want either. We want the attendance list. Okay, there's no hands. I'm kind of glad, because I'm kind of tired today. So I want to introduce our last song here, as long as we're at the last minute. And this is another inspirational song. And like I said before, the best songs in the world are the songs that are also prayers. So if you thought that this person was talking to God rather than his girlfriend, you could probably understand it. But the title of the song is Josh Groban's most famous song. It's You Raise Me Up. And the reason why I like it is because that's what I would like to think that I'm doing sometimes in teaching you, you know, American medical school pathology education. I would like to think I'm raising you up a little bit too. So let's hear from Josh Groban and we'll call it a day.
When troubles come and my heart burden me, then I am still and wait here in silence until you come and sit a while with me. You raise me up so I can stand on my
Rock on, you buzzards.
The